everyone. This is Sushma Patil, Lead Genetic Counsellor from Neuberg Center for Genomic Medicine. It's a pleasure today to be introducing Dr. Arti Pawaria, who is the Chief Pediatric Hepatologist and Liver Transplant Physician at Sir H.N. Reliance Hospital. MD Pediatrics, followed by DM Pediatric Hepatology and PDCC Pediatric Gastroenterology. She has won national as well international awards, including Young Investigator Award, Original Research Award, Best Research Paper Award at different conferences. Thank you, and over to you, Dr. Arti.
Thank you very much, ORDI, for giving me this platform. And I think that this platform and ORDI itself, it's not about a meeting or a webinar that we're doing today. It's about what we all together can do. And the way I put my presentation is also in a way where I will put it to ORDI and to other organizations who wish to work into this area to understand how they can do it. Because if we understand the problem, we'll get the solution. So I start my presentation on rare liver diseases, the unified platform for diagnosis and management. And the first thing is that we understand what is rare. Rare, even though rare is not very few. There are almost 7,000 known rare diseases in the world and 300 billion people suffering from it. The major challenges across the entire globe are related to delayed diagnosis, limited research, and a lack of specialized treatment centers for these diseases. However, in children, and especially in India, we have very unique challenges as well. We know that because of the sheer large number of population we have a lot of children who are suffering with liver diseases. What we need for them is a comprehensive support for all these families. Additionally, just because we have high number of children being born into the country, we have at present around 1.6 million children who are under the age of 18 years and are suffering from liver cirrhosis. That's a huge number. And we alone cannot fight. People working in silos cannot really do justice. So all of us have to join in together to identify what needs to be done. Apart from the sheer burden of the disease, which is a problem, there are challenges of unavailability of uniform healthcare facilities for all. We have in the country one of the best medical facilities of the world. However, the inequalities between the income, the need, and the remote locations in the country does not really make it accessible to all the people here who can, especially children who can take it. And hence, there are very unmet needs in pediatric liver diseases, especially the rare liver diseases. Even though they are rare, we have around 40% of all of them, which if treated and diagnosed timely and treated appropriately, can even be prevented. There is another 40% of them which we can treat appropriately and they lead a good quality of life with their own liver. That means there are only 20% of them who will require a transplant. So 80% of a problem can actually be saved and done away with if we have a preventive and an early diagnosis and treatment, optimal treatment for these children. And this is what I feel organizations like ORDI, and there are many other organizations, very good work have been done by you yourself and by many other organizations during the years. Time has come where we all join together and work towards it. Why? Because despite many people working, many organizations wanting to help and really working hard, the problem is we have a fragmented system in place. The patient is somewhere else. The primary physician who sees does his best, but of course, not everybody is trained to handle liver diseases. Then we have some laboratories which are specifically located in certain parts of the country. In the rest, they're not there. There's a major challenge between a public and a private enterprise, which is a large difference. Then specific genetic testing availability is at smaller areas. And then finally, the specialist consultation come, which according to me should have been the first one even before the investigations and many other things. So all these things need to be swing together and made a beautiful garland. And in the small beads of that garland, each one by one should be very nicely done. Now I looked at it. This specific slide is not a new slide. This is what my brain has told me since I started clinical practice, and it shows that though we have large number of population, not all of them are going to require all the utilization and the resources which are there in the quaternary and the tertiary care. Some of them will. Why do I send all of them walking to another center when among them who needs extra care can be looked at by a video consultation, and then the family can be counseled, and we can check and see where they belong to, where they can get the investigations done, how can we get the treatment to them, many other things. And this, in my way, is a real solution to not just having the treatment of the diseased child. We also need to support a family. There's a financial burden to it. And also, there are many social obligations and the support that is needed for a successful management of rare liver diseases in children. So that means we know the challenge, we have a vision, we know that we want to give appropriate care to all the children, and we need to have a way forward. The way forward is, of course, as I said, an early diagnosis and referral, expert consultation, because there are not many, unfortunately, at present, there are not many liver experts who are there in the country. But I think all of them can be wherever you are, you can still get in touch with them through a video consultation. Testing, genetic testing if required, any access to the treatment and the transplant pathways. They don't need to really stand in a quaternary or tertiary care unit every single day. Many of the things can be still done in tier 2 and tier 3 cities, and they can come and go as per needed. That means there is always a referral up and a referral down, because they need to go on with their normal life. The family needs to go on with their normal life apart from treating the patient. They cannot just shift their entire family base to a metropolitan city where there are large hospitals to treat their child, or where the doctors are available 24/7. They probably don't need the specialist 24/7. They need specialist consultation. That's very important. And then come at a time when it's required, and then seek a satellite care at the wherever nearest to their house, which they can take. So that is important, that we need to just have not have the children being treated. We need to have the families empowered. That means even if, for example, somebody is living in Nasik, he doesn't really need to come every day. There must be pediatricians in Nasik. It is my job to identify a pediatrician, or if the family tells me they go to a specific one, or I can connect to them via written letter or via email or via any digital way, and tell them, see, this is my plan. This is what needs to be done for the child. If there is anything worsening, if you feel he's not well, please ask the child's parents to see me once and then go back. And that is how you're going to have better outcomes of rare diseases, because initially maybe every parent is wanting to take this child to all the centers, but gradually they all get very, I would not say tired, but it is a major, major challenge to have a chronically diseased child in the family. But our job is to support the entire family, and in that way support the child. So the government very graciously had come forward, and this talk would be incomplete if I do not talk about the National Rare Disease Policy. When we talk about the National Rare Disease Policy, government graciously put it in 2021, has been made amendments to it as recent in 2024. Now they have specifically for liver diseases have given money allotment for liver transplant as a single time therapy. They also have allocated budget and good proposal and a strong plan for those rare liver diseases which need special dietary support. That means special formulas which do not have one specific nutrient which the child has disease to, and also the medications. Wilson's disease is one such disease which you can see here, in which the government has put that lifelong therapy will be given by the by the government. But still, many other things, for example, the counseling, the prenatal testing, the sibling screening, that is something which we as a whole cohort and a support system can develop. And apart from the diseases which are listed in the rare disease program, there are many, many other pediatric liver diseases which are still rare and they are yet to find their position into the list. We have a lot of patients who come here everywhere in the country, wherever you go from north to south, from east to west India, everywhere the diseases are there and they also need support. Hence, we should not be saying that the government alone has the responsibility of taking care of them. It is all of us in our best way where we can help them. Now, how do you bridge the gap? The gap is that we don't have a system which says, if you look at the lower half of the slide, we don't have a system to say who is going to link the family, the liver units where expert managements are done with the center of excellence which the government has designated to implement the national rare disease policy. Where do we find information about this? Which treatment management options are there for specific diseases? How do we get if some family wants partial financial support apart from what the government takes, psychological support, information, advocacy about future children, about the present children, and how does the system take forward? These are the things which I very strongly believe is the need that we need to have a liver network for children because each one of us is a resource. Whether the child's family, whether the treating physician, or whether organizations like ORDI or many others, they're beautiful organizations which has been working for the liver diseases in children, and we have been very thankful for them for all these years that they have helped. So now we all need to make an ecosystem, and I will come back to this. A major part of this ecosystem would be a digital initiative. Why do you need it? Because many things can be done within the same office time if you make a path. If you make a path, make an SOP, make a plan, and then make it foolproof. Many things can be done. Once we have that kind of a network, doctor is not the only person who is a part of it. You all that are the family, the parents, the other patients whose children got treated, or who can actually, in real sense, connect with those families, make them understand the doctor's going to do its work. Similarly, all the other resources which we can get from all there, that means to tell the family that they're not alone. Every new diagnosis is not alone. They are just entering into another family, which is very supportive, a large joint family, and we welcome all of them so that each of these children can be given the best life forward. And one important part where we can never disconnect a child with a mother. In a house, if a mother is empowered, the entire family is empowered. She is the one who goes to work also many times, who is the one who feeds the child, who is the one who spends the maximum time with the child. And if we are able to psychologically support her, apart from all the other financial and extra support that we need to give to the family, and make the mother realize that we are with her, especially in the genetic liver diseases where because of sometimes the social stigma that goes on for a mother of giving birth to a diseased child, which is absolutely wrong. But until unless we as caregivers, we as physicians, you as patient support groups, you don't reiterate it and re-emphasize to the family that new mother who just got a diagnosis of a child is probably going to go back and forth with this guilt as well. So empowering the mother by counseling her, by making her understand the disease, and education level does not matter. It may be difficult to sometimes educate in scientific terms to some of them. But believe me, the human brain, even if somebody is illiterate, they still have those emotions, they still have those understanding of life. So you explain to the family, explain to the mother, make her empowered. She should be able to pick up danger signs. She should be able to say, yesterday my child looked better, but today it's not looking better. I'm going to pick up this call and call to that center who's going to give me that support. That kind of empowering is very important for each of us. I always say that we may talk about quality improvement everywhere, but actually solutions happen because each family, each patient will decide what is right for them. There's no single method which is going to put to all of them. A patient in Jamnagar versus a patient in Delhi versus a patient in Dibrugarh versus a patient in Chennai, all of them, depending on the household situation and depending on the disease, depending on the age of the child, depending on whether it is a new diagnosis or a child who was on treatment, every decision has to be taken by the parents, but they should be offered an entire panel of support, whichever they seek at that time is right for their children, is what they should be able to take. And our job is to make that ecosystem. So the call for action is we have to reduce the cost of social, material, and economic hardships. And believe me, I did not use the term medicine here. Disease and medicine is a different thing. Each family needs to have a support for the social cost, for the material economic hardship. We should have patient support groups. We should have ways to do subsidized investigations and then relate to the treating physician, be it a primary physician and the primary physician relating it to the specialist or directly going to the specialist, reaching them out even on a teleconsultation is the best thing to do. Subsidized drugs must be made available, and this individual patient can't do, organizations and bodies does. We must have video consulting follow-ups to identify early complications and keeping them compliant to medications. And a lot of counseling and preventive aspects can be easily dealt with in telemedicine. I'll give an example of Wilson's disease. This is one of the rare liver diseases already has taken approval, has got approval from the National Rare Disease Policy for medicines as well as for transplant. Now, this is a disease where effective prevention is also available in the country. Treatment is also available. But what we need is to make an umbrella under which all the patients can come in and seek their support and help wherever they need. So just one brief about Wilson's. It is one of the liver diseases, very common in India. Almost 50% of the children suffering from liver disease in the country at present have Wilson's disease. As compared to the world, China and India have the highest incidence of Wilson's disease because of our genetic makeup. Within India, Maharashtra and Gujarat have the highest incidence of Wilson's, again by virtue of the genetic makeup that they have. So this is a liver disease which is associated with excessive copper deposition in the liver, damaging the liver and then damaging the brain as well. So there are two kinds of associations or features that happen. One, the children present with only liver disease. The other, they present with neurological disease. Many of the adults are also there who initially had the disease in childhood and they're now adults. Some of them sometimes gets diagnosed for the first time in early adulthood. And we have a lot of work being done in Wilson's, but we are far from what needs to be done. And if you look at this graph itself will show you, see how much is the burden of Wilson's in childhood. And this is a disease, I remind you, which has prevention, which has diagnosis, early diagnosis, easy diagnosis, and also treatment. And we look at the data across the world, it's a genetic disease. We find it in all the populations. That means we have one more armamentarium with the genetic diagnosis here. But again, the problem in the country, like other liver diseases, which are rare, is that there's been a lot of diagnostic delay. And when that happens, by the time they present to the specialist, the complications have already set in. What if everybody knows in the country about these diseases? Like everybody knows about COVID. Previously, nobody had heard about it. So it's just a matter of engaging. It's just a matter of commitment. And that really pays off in long run. I've seen so many children with Wilson's disease, adults with Wilson's disease, who grow up as adult with all features, some because of the way the disease is, whether they got treatment or not, and also depending on what kind of mutation they have. Some of them will only have liver involvement, some of them will have bad neurological involvement, some of them will respond to management, some of them will not respond to the drugs, some of them will require transplant, some of them will not require transplant. So that means even with the same disease, you have different presentations. Now, how do we make and group them? Which children will, will are going this way? Which children are going that way? That can only happen when there is a centralization of the information, so that if we have a child with liver disease of Wilson's disease, the pathway is this. If you are liver with neuro, you are this. If you are with neuro, you are this way. And we should be able to give them support through multiple stakeholders. It's not just a government. You need to have multiple stakeholders in which even pharmaceuticals come, in which even genetic labs come, in which the family comes, and then support of finances come from philanthropies. They do come from many government centers as well. So the need is that we need to have a network where we are able to give them management. And until unless we have disease specific cohort. This I've put as a Wilson's disease patient cohort, but we need to have patient cohorts of specific diseases so that each one of those persons in that cohort learns from each other. We should be able to burst the myths which are there. We should be able to give them advice. We should be able to even handhold those children who are now becoming adult to employment, to understanding what is self-resilient, to be able to give answers to them. For example, can I swim? Can I go to this? Can I do this? Can I join another workforce? Things like this also are very important. One important thing why I picked up Wilson's is because it is an autosomal recessive condition, which in simpler term means that if both the parents carry one of the affected genes, there is 25% chance that one of the children will be Wilson's disease. However, 75% chance is there that the other siblings of the affected child will not be Wilson's. And if I say 70% chance of not having a disease and 25% of chance of having a disease, will each and every parent not want their already, if they have children already, or if they plan future children, to not know whether my second child, third child, or whichever child this is the other child also going to develop disease? And if there is a risk that the other child will also develop a disease, is there something I can do to prevent the development of disease because we pick it up early? This is essentially what Wilson's gives us. So for every child who we diagnose as Wilson's, mandatory sibling screening must happen. Parents may be very overwhelmed with the diagnosis of the first child and even be little less receptive when we tell them, okay, even if you have this child, we're doing the best, but I want at this time your other children to also be screened. They may say, I don't care about others, they're just fine. I know them, I'll do it later, but you just make sure this child does well. The point is, it's a simple testing. If you're testing, the child is a asymptomatic, potentially Wilson's child, we can give medicines to the child so that they do not develop the liver disease, which is very important. So this quality improvement should never be missed in any of the Wilsons. Now, the need for ecosystem is very much there. I hope by this time many of you would have realized that we really need an ecosystem and not just one or two people or not just one or two stakeholders. And there is also a need of commitment for the liver diseases. If we have this, we can really make a difference to this part. And this is exactly what I said, that commitment means not to forget that me being despite a doctor, I cannot forget that if I tell a patient to come to me and show me the liver function test who's coming from 1000 kilometer, I should be mindful of how much cost will that family bear to come to me and then go back. And the loss of job, the loss of work hours, the loss of school, the psychological effect of it, and the loss of wages that will happen to that family. And hence, when we make an ecosystem, we should be taking care of both the disease financial burden, which is the investigations and the medications, also the other costs to that family, which the family has to go on with. For example, the transportation challenges, the food insecurity. They at the end of the month they have less money for the household, food and the necessities. Housing somebody was living in a rented accommodation, but now his got into a economic hardship of paying the rent, what is going to happen in long run? They don't. The person or the family doesn't want the child not to be treated. But what happens in long run is that they may feel, rather than going for an OPD this time or buying the medications this time, okay, let me do it after 10 days because I need to pay the rent of the house. So these are the ecosystem which I believe cannot be completed only by a physician. They have to be major stakeholders. Stakeholders means institutions, organizations which come forward, philanthropy which comes forward for these things. And when we do this, a lot of our diseases will be taken care of. For example, it's just not one single. Somebody came, somebody got a diagnosis, everybody is happy, everybody is patting their backs. Okay, we saved that patient, or we gave the medications, now he's better. We have to be mindful and handhold them all through the life. Because when a treatment is started, there can be some complications, there needs to be a follow-up, there has to be changing in the dose. And then every time if that patient has to come all the way, it's a really very, very significant cost, which I believe in these modern times when we even learn in online courses and do IIMs and so many courses are going on, can we not create a plan for digital inclusion of all these support systems for our patients? For example, look at this. This is the standard data which I look at my patients when they come, rather than telling them, okay, when did you do your last test? Show me the report, and then I'm mindful of what the previous one was. Now, how do we expect everybody to handle a patients or the families to handle it? Except very rarely, whose parents are very tech savvy, they cannot do that. So it's not the responsibility of the family and the parent to be able to consolidate the data. It is the ecosystem which has to consolidate the data and later on even understand from all this, okay, which child responded, which child did not respond, and things like this. So these are important things that needs to be learned. We have to tell them when are they going to come. Will they just come when they want to come, or do we give them information saying, okay, this test has to be done this time, this test has to be done that time. All these are important support. Now, when we say for ecosystem, this is the ecosystem. Counseling, education, prevention, early diagnosis, management, counseling, everything connected. It may not be in the same building, it may not be in the same city, but everything is connected. That means like-minded people work together and make it happen. For example, this is from both. I've still never seen the family, but it's a family of 5 sisters who have three of them has Wilson's disease, one diagnosed, two later got up in sibling screening. They already did a genetic testing before I could see them. Somebody else asked them to see, but do I really need to really call everybody to me for every small thing? There are people in their center as well. But if somebody needs an expert opinion, that can be done and it makes a lot of difference to them. So why are we not utilizing all these for our patients? It will make a real difference. And this kind of umbrella should be covering all of them. See, if you're able to diagnose asymptomatic children as old as 1.5 years and preventing the onset of liver disease, what is all needed is just a good education, information, reliable information, and an ecosystem for all of them who are in need to reach out. And this talk wouldn't be over unless I talk very briefly on transplantation. And one of the ways why liver diseases got better is because even though 20% of them would require transplant, but before the advent of transplant, all these children had end-stage liver diseases, and that was essentially fatal. Now that we have transplant, both living donor and cadaveric donor, which means the liver taken from the deceased donors, many children are able to live, and I really find this is a blessing when those who need transplant will get transplant. But be mindful of not rushing children into transplant who can be saved with medical management or who can be even prevented on medical management. This is what the country needs. If I have 10 children with liver disease, 8 will be okay without a transplant. I have no business to run to transplant for those 8 children. And you see that India has done phenomenally well in the transplant. We are second largest transplanting country in the world. We have done transplants for all small, big, small size children, all difficult transplant, but you realize, look at the map, they're all only in the black spots which are there, which are covering. It's a huge country with only few centers. And mind you, none of the government centers are doing transplants at present for children. And if you see, do you see 12% of our children still are Wilson's disease or getting transplanted? And all this entire circle is liver disease. So we need to have a very good ecosystem for the liver disease children. And I end this by saying that until unless our roots of early diagnosis, appropriate treatment, and a good, strong cohort of support groups like ORDI, like the Praveen Agarwal Foundation, like many other philanthropies which are running, we won't see our children like these beautiful fruits. We need all kinds of support. It includes awareness, it includes good information, access to telemedicine, access to healthcare. It needs information about children and a multidisciplinary care. Thank you very much. I'm open to any questions that you have.
Thank you, Dr. Arti, for such an insightful talk. And I think the most important takeaway is that building that ecosystem so that all of these families are well supported in this tough, rare journey. And definitely, ORD and physicians, clinicians like you make a lot of difference to them. So, thank you for this talk.
Thank you very
Open
much.
to questions. You can put it in the chat. Till we have questions, ma'am. So, under the rare disease policy, if someone has to apply for a transplant, what is the procedure? How does it work?
So see, right now there are 12 centers of excellence in the country, and all of them are government centers. Unfortunately, many of them do not have pediatric hepatology. Most of them do not have pediatric hepatology opinions. However, if the disease is diagnosed outside, if there are adequate information about the diagnosis, and if some of the diseases require genetic evaluation, which has also been done, those children are accepted under specialist expert opinions, even if the opinions are from the non-government centers, because the government centers do not have Department of Pediatric Hepatology at present. So they will, on the expert opinion, the Rare Disease Center or the Center of Excellence will give a acceptance clearance and then send off appropriate letters to the Ministry of Health. We have had children with Wilson's disease being transplanted at KEM Mumbai, which is one of the Center of Excellence. Though it required us to, there is an association between our hospital and KEM, and this is being done as a part of improving healthcare in the country. And that has been done, and money was allocated. Though this is not a usual practice everywhere, but slowly it will also become. The important thing is to get to the diagnosis. And if you don't need a transplant, you need to be on treatment. Transplant should be done to those who need it. There'll be so many who will be okay without it. Each one of us would not want to get transplanted any of our near and dear ones until unless it is the need. So awareness about the disease and prevention is the most important thing, especially in pediatric population. They have a reserve. The liver regenerate, the liver remodel. You will have really bad decompensated liver disease. Yeah, if they're Wilson's, then also they improve upon. That is the beauty of pediatric liver.
Any specific message to the parents, ma'am, in terms of not giving up or the need for proper follow up once the diagnosis has been made?
So once the diagnosis is made, I think the onus is with the healthcare provider. And I really feel so. They may be new to it, the healthcare provider is not new to. And if the healthcare provider is not a resource person, think of who it would be. So the need for follow, it's just not the need for follow-up. It's also to tell them the way to follow up. Just telling somebody who's come from 500 kilometers that after 10 days I want to see you again. Did you realize how many people come with a child all the way from there? How are the ticketing system? How are the reservation systems? Are they going to come in cars? No. Are they going to come in trains? Do you get the train tickets? So these are realities of family who we have nurtured over the years. So I always say that if you are aware of the ecosystem, if you are aware that a video consulting can be done, until unless you tell them how can it be done, until unless you have a person sitting in that city or a person who you think can look at the drug distribution in Gujarat, for example, if the patient is from Surat. So you can tell them, okay, why don't you speak to this person and he will guide you to the nearest person. But the resource person is the physician, or for example, if they come to you if a genetic disease is being diagnosed, and then any family whom they may reach out to. If you feel you have few families who are already there in Surat for them, you should tell them, give them the contact number, tell them, for because they have gone through the journey, why don't you speak to them once? If there's still something, you can always connect back to me. So there are so many things about diet, about many other things, but you should be doing your part of counseling, giving them the ecosystem platform, whatever it is, even if it is not 100%, give it. They will realize the value of ecosystem, and with organizations like ORDI and many others, they can really make an ecosystem. Patient alone or a doctor alone cannot make the ecosystem, or even a government alone cannot make the ecosystem. That is for sure.
Agreed, ma'am. Any questions from the audience?
I don't think if they can unmute themselves or not. If anybody can unmute themselves, they may ask, or you may put it in the chat box. I'll be more than happy to answer. Are the audience, can they unmute themselves? Chetna, can the audience unmute themselves?
No, ma'am, not possible.
So, yeah, that's why. But anybody can put questions if they want.
Yes, ma'am, they can put questions in Q&A session.
So let me just ask you, Rupma, how frequently do you get to the diagnosis of their rare liver diseases? How frequently do these come up as samples to you?
This is usually through the clinicians, and a lot. Now the number has increased a lot, and mainly Wilson. Yes, as you correctly pointed out, the Wilson cases are, yeah, they are
Especially
coming
in Gujarat, there
to
must be
us.
many of them.
Yes, yes.
So I think that ecosystem information should go from, if you and I are in the ecosystem, the information has to go to each one of them.
Yes, where to get tested, and a need of testing, as you rightly pointed out, for the siblings,
Yeah,
family
that's the
members,
beauty
is
of
so
it.
important.
That's very important.
I think, ma'am, would you like to share any inspiring, yeah, patient story or family story for the
There
audience?
are so
I know this
many.
is,
There are so
yeah.
many. And it's always very heartening to see them. I don't know whether it's just by coincidence, but majority of our Wilson's disease children are actually school toppers. I don't know how God gifts them. One of them got into IIT Bombay. One of them is a CA. Despite everything, one of them was the Mumbai topper also for class 12. So these things just tell me that they are just blessed. God gives blessings in different form. They grow up understanding the value of life, and I always strongly believe that as physicians, we're humans first, and hence I'm not sure. I'm probably the last. I could have done the entire talk about transplants and many other things, being sitting at a transplant center, but I've always advocated, and I firmly believe that a physician who has now understood that who will require a transplant, they have really understood who will not. And if we don't make ecosystem, or if we do not initiate ecosystem, I don't expect anybody else to even understand that there is a need to initiate ecosystem. So I feel that this is my responsibility. And if I'm able to voice it and put it across to platforms, and I make sure I always voice it out to appropriate platforms, because sooner or later, like-minded people will join hands and make it. And once the system is made, then the beneficiaries are multiple.
Thank you for that. I think we don't have any questions as of now.
Yeah, so I think we can close the session, and maybe sometime we can have a different session just on Wilson's disease, I think, because I'm sure a lot of patients within Gujarat and within Maharashtra are really, I feel Wilson's is one of a lifetime effort to put an ecosystem for them.
Agreed. Thank you everyone for being there. Thank you.
Thank you. Thank you. Bye-bye. Thank you for being here.
Thank you so much, ma'am.
Thank you.